Hello, Dr. Vibhor.
Hi, hi, good evening.
How are you? Good evening.
Yes, yes. So actually, yeah, I'm logging from the link.
All okay, Reepa?
Yeah, hello.
Hi. Hello.
Hey, sorry, my computer was updating. Zoom was taking a long.
No worries.
Yeah,
Where are you? Still in consulting or back home?
I'm back home and home now. Yes. So you'll be having like more members on this platform, or only nine, and the people will like how
No,
does.
so we have given a time of 9:30 and whatever member zones and groups that we've shared this message, it
Mhm.
carries a Zoom link for 100 people because that is the max that we have. And beyond that, we've provided a YouTube link. So if the numbers cross 100, then they will join using the YouTube.
Okay, but that will be live at YouTube also.
Yes, yes, yes. And then, of course, the recording link will also be shared.
So if they ask questions, they will be here in the chat box. Those
Yes.
who are attending
Those
from.
who are here on the Zoom will be posting questions in the chat.
Mhm.
And of course, Dr. Reepa, who's our moderator, our EB member with you today, she will be taking up just to begin with. And then
Mhm.
it's going to be like an open platform.
Okay.
So anybody amongst the participants, as the flow goes and as the discussions go, they will be discussing.
Yes.
So it's all about gastroentero and pediatric hepato from the expert, everybody and anybody who wants to know anything.
Okay. Great.
Good evening, ma'am. Good evening, sir. Welcome, sir.
Hi. Good evening.
So you had your dinner? Madam, you had dinner?
Kind of.
What about you? You had food or not? Your meal. So for the GI session, you can't come empty stomach. And then the discussion
I,
will go
for
on
all that you know,
for
she'll start with her personal complaints then.
Hi, Vipul. How are
Hi.
you?
Hi. Good evening, ma'am. How are you?
I'm good, good.
Great.
Yeah, nice to see you. We're just on the phone only talking to each other.
Good evening, sir.
Yeah, hi, good evening.
Hi, good evening.
Hello, sir.
Good evening, everyone.
Sir, good evening.
Hello, sir.
Oh.
We'll wait another 2-4 minutes, Dr. Vibhor. That's okay, right?
It's a weekday, so everyone is busy in the practice. So a little bit delay is expected. Plus Mumbai traffic to reach home. Yes.
we start, Nehal?
Should we start, sir? Okay. So, very good evening, all of you. And I welcome you all back to this season 2 and episode 1 of our very famous and most liked Webflix series that we had done it last year towards the end of the year. And this is going to be an activity, online activity, on every last Friday of each month. Beginning today, today is the first episode, and it is all about gastroenterology. And we have an expert here with us, Dr. Vibhor Borkar. I think everybody knows him. He doesn't need any introduction. And he's a consultant and a director of pediatric gastroenterology and hepatology with liver transplantation at the Nanavati Max Hospital. He's a visiting consultant as a pediatric gastroenterologist to many other hospitals all over Mumbai. And of course, most of us must have heard him on a lot of CMEs and conference platforms. So thank you very much, sir, for joining us today and giving us this opportunity to have you on this platform. And of course, moderating this session is with us our very young and dynamic EB member, Dr. Ripa Agrawal. And she's into private practice and she's a visiting consultant at the Sion Hospital. So with this thing, we start this episode. And just to begin with, Ripa would be going through some of the commoner topics in gastroenterology. And as and when they come up, this is going to be a free platform. So anybody who would like to put in any questions related to that can put up in the chat box and these would be taken up. And the flow would be that. So it is not going to be just one a particular topic that we are going to have on. It's going to be a very bilateral and a very interactive session. So I think with these few words and we would start this. And I would like Ripa to take over from now on.
Thank you very much, madam. Very good evening to all of you and welcome again, sir, Dr. Vibhor, sir. I think in this era where, most of our questions are being answered by pre-programmed bots often, I think to have an expert live with us who will be, sharing his experience and helping us out in our day-to-day practice is remarkable. So thank you again, sir. So I would delve into the questions directly. It is common that, even I am a mother, that we are obsessed sometimes, with, giving milk to our child. We want our child to, finish that glass of milk before going to school. So, Vibhor sir, there is a, 9-year-old healthy boy who came to me last week. And his mother used to always give him a glass of milk before going to school. But since last 1 month, he has started vomiting this in the school bus itself. So, sir, are we looking at lactose intolerance?
Yeah, I'll take the question. Yeah, first of all, I will like to thank IIP Mumbai for this, I think, very innovative approach towards a specialty. I'm quite excited for the today's session. Okay, so to begin with the first question, so the question, so you asked about that the child has taken milk and after some time the has been vomiting. Okay, see, you have to remember that most of the GI symptoms have very, very non-specific presentation, so they can overlap with many of the many of the other conditions also. So it is an acute onset, and generally, if you see the lactose intolerance means to have this lactose intolerance symptoms.
Hmm.
Milk or the carbohydrate component, undigested carbohydrate component has to reach the colon only then, and then has to be processed by the bacteria, and then you will have the symptoms. Stomach emptying time and then intestinal transit time, it will take around 3 hours to reach colon and then bacteria. If you're having within 1 hour, very unlikely that this is related to the milk intake or maybe a lactose intolerance. This kind of a correlation that you are saying. Now, if suppose this child who has an vomiting while in the bus, whether it is a new onset of a motion sickness or this child has not any has basically a constipation kind of thing where he has not passed stool and after the some meals, some gastric motility has started, he has pain, and as a response to his vomiting, there are n number of things that I will consider here and will like to approach it. In such situation, I will just ask them to change the probably something else and see. Then again, this lactose intolerance, it will not be just related to maybe the morning. Anytime your child takes, he will have the complaint. So just try changing the schedule and see if the child has a complaint or not.
Okay, so you mean to say that suppose if it is within 3 hours, we will not consider it to be lactose intolerance?
Yes, so scientifically it should not, except few cases like
Hmm.
small bowel bacteria or both. So bacteria instead of colon, they are reached to the small intestine. Yes, then it's possible, but otherwise it should take some time. Immediately in an hour's time, this will not happen. But yes, sometimes it can happen. Suppose the child has a past experiences having going through the lactose intolerance, then this nausea can be just because of the past experience that after the milk he has this abnormality. That's how I can stretch it to the lactose intolerance. Yes, but so see, but it's a very vague complaint. Just it
Mhm.
one-to-one correlation with the complaint and the diagnosis is not possible.
Okay, sir. So, sir, in such conditions, so should we ask the mother to have a diary of for her symptoms? Like, how would we approach this then?
First thing is just change the timing and see whether it is
Hmm.
really with the milk or something else. There is a lactose intolerance. The complaints will be apart from vomiting, there will be a bloating of fullness. Then the loose stools can be there. Another one is the first. So the loose stool will depend on the amount of milk is taken. But the more common will be a farting because this will be a lot of gas production. So my mother will complain, okay, nowadays the child farts a lot because through other maybe the students maybe make fun of the kid and other things issues will come. So vomiting is not very predominant complaint of lactose intolerance.
So,
Younger kids, infants, diarrhea, explosive stools, perianal rash. Older kids, mostly the discomfort, bloating, farting. This is more complaint.
well taken. So that means the lower GI symptoms are more common with lactose intolerance than upper GI symptoms.
Yeah.
Is that- Okay,
But
so
they can have a bloating, nausea. They can have a nausea because of distension. So there is no complete demarcation.
okay, sir. And sir, is it like sometimes we have seen that, some kids who were in India initially and when they move abroad, then they develop lactose intolerance. Is that true lactose intolerance, sir?
See, I don't think it is related to the migration to any other country. Even if they stay in India, as they grow, they will develop lactose intolerance. So we need to see what are the different types of lactose intolerance. One is the congenital intolerance, very rare. The child will be symptomatic right from the birth. Another is
Hmm.
the primary lactose intolerance, and third is the secondary lactose intolerance.
Yes.
What you are talking about is the primary lactose intolerance. It means genetically Asians or those who are living in the tropical countries, they are programmed to decrease their lactase concentration in the villi. So, so that's why as we grow up, mostly after 5 or 6 years of age, gradually our capacity to digest lactose decreases. That is because we don't need milk to survive.
Hmm.
Reason for which we need a milk later on in the life is for our calcium and vitamin D supplementation. We are
Hmm.
taking a small amount of that, that is sufficient. We don't need to take the milk as a major calorie and a protein source. So
Kindly mute Dr. Khan. Thank you so much.
now those in the people from the European countries where you can see there is a very less quantity of a sunlight, there they have evolved to maintain their lactase production so that they can keep on their milk intake as a source of calcium and the protein because there is less sun exposure. In a
Yes, sir.
tropical countries, there is a nice sun. So over the thousands of years, we have genetically programmed to lose the lactase. So lactose intolerance is our inherent symptom. It is not disease. So primary
Okay.
lactose intolerance we will have. So do not consider it as an abnormality. You will have it. Now there are certain conditions where lactose intolerance is more than what is expected for the particular age kind of thing. So these are like any maybe the after any bacterial infection, yes, there will be loss of top of the villi. Very classical example for our pediatric age group is the rotavirus infection. Apart from that, small inflammatory bowel disease. Sorry. irritable bowel disease, a very common IBS. 30% of the IBS population will have a lactose intolerance. It is very, very common. Along with that, any surgical cases after the diarrhea, then small bacterial overgrowth, small intestinal bacterial overgrowth. All this condition, the lactose intolerance is very, very common. Now, so this was basically, that was a secondary lactose intolerance. Now, secondary lactose intolerance will depend on the duration of the disease. For example, once you're taken, suppose an acute infection, once the infection is gone, villi will regenerate and the lactase production will be as per the age. For example, we are dealing with the infant, generally the cycle for the enterocyte, which goes from the base of the crib to the top of the villi, generally in adults it to 5 to 6 days. So in adult 5 to 6 days, your secondary lactose intolerance will recover. Same thing, younger the age group, longer the time. In infant, this cycle may take around 3 weeks. So that's why if you have a kid with the lactose intolerance, which is secondary, we ask them just to stop the milk for 2 to 4 weeks. Of course, it is a range. Individual to individual variations do vary. But the thing is, don't label them as a permanent lactose intolerance, and after 4 or 5 years also the mother is not basically giving the milk in the fear that it will be a problem. That may not be necessary. Okay, for example, the diseases like a celiac disease. You diagnose the celiac disease, you're treated. Then the first 3 months, generally good amount. Once you've taken care of the gluten from the diet, the villi regenerate. So in a 3 months time, this villi do regenerate, and after 2 to 3 months of time, they can start their milk intake. So we have to individualize the therapeutic approach to lactose intolerance.
Yes, sir. So, sir, now, as you mentioned that one of the causes for secondary lactose intolerance is acute gastroenteritis. So, so many times, the mother stops giving milk, once the baby has started having loose stools. So, do you think that's a correct approach?
So means
For
I
a
will
9-month-old baby, suppose if
so
that
I will
baby.
take it as a 2 point. One thing is
Mm.
how, so if in a child, so if the child has a lot of perianal excoriation or basically forceful or purging, then probably yes, it is a lactose intolerance, and then yes, reduction or decrease is warranted. Blanket reduction of the milk or stopping of the milk may not be required. Another thing is another very important, like common practice is to do a stool routine examination, and if the stool is acidic, stopping it. It's not required unless it is causing clinically significant lactose intolerance. Because see, you have sudden, now you imagine that baby at 9 months whose predominant diet is milk.
Milk, yes, sir.
It needs the nutrition. What we are doing is suddenly on a one day we are taking away stop milk now. So, and in this catabolic state, they need good nutrition. So, unless it is medically indicated, I think it may not be done. So, what mother need is just reassurance.
Yes, sir. So we should just reassure the mother, and if clinically indicated, then only the milk needs to be stopped. Otherwise, we should not stop it. And so similar for lactose intolerance, there is a question that if given by Dr. Neeta Jagat, that does this lactose intolerance depend upon the geographical location related to the change in the microbiome because of the change in the diet?
See, Ms. We just discussed the pathophysiology. If so, anatomically, your small intestine is proximal and large intestine is the distal. If your small intestine is the digesting all the lactose, whatever the bacteria is there distally, they won't get the lactose to basically work on it. Okay, so as such, moving to a different geographical location and changing of the microbiota should not scientifically or logically affect the lactose intolerance.
Okay, sir. Okay. I invite questions from the audience. Kindly put your questions in the chat box. Now, sir, suppose we have a 6-month-old baby and who is healthy, but a stool routine was done for the child because for some reason, and there is what we find is occult blood. So, sir, are we thinking now about cow milk protein allergy, or should we just disregard it?
Like why the stool routine was done?
So, sir, the stool routine was done because this child also had some urinary complaints. So there was a doubt whether there is a parental diarrhea which is coming up.
No, but for parental diarrhea, there should be first diarrhea.
Yeah.
So, so we should have to be very specific. First thing is ordering the investigation, whether it is
Yes, sir.
clinically required or not, and whether the results of the investigation is going to make a change in our prescription or advice to the parents. Okay,
Right, sir.
so means if you want to, there is occult blood, there can be a number of reasons for occult blood. It's means in a diarrhea child, even the perianal excoriation, minor perianal cuts, they can also give through RBCs, and that can also cause an occult blood. So occult blood, so it should be just not the qualitative test, it should be a semi-quantitative test. Means along with that, it should also mention whether it is a trace or it is 1 plus 2 plus 3 plus 4 plus. That's what that is the semi-quantitative analysis or the perspective to the occult blood. So zero, like means a trace, 1 plus 2 plus, till that I may not give much importance to this occult blood. If more than that, depending on the clinical scenario, maybe 2 plus, sometimes I may take significant, or 3 plus 4 plus is definitely is the significant occult blood. Now, so this is will be the interpretation of the stool occult blood. So you see what mechanism or what methods it has been done. Now you are saying is a 9 month baby. Most of the 9 month babies are on the iron supplements. Okay, till one. Many of them we
Yes.
prescribe. So you see which method it has been done, whether that method is whether like so clinically if they're taking a GUEC test, then it will even the iron supplement it may be positive. So you have to interpret it accordingly. So just because you said it's for means you asked the question that that was some urinary symptoms and occult blood. So milk allergy will be a
Not
clinically,
like.
yeah, I'll not keep it. But yes, interpretation of stool occult blood is important.
Okay, sir. And so, sir, if we have a stool occult blood 3 plus, in which setting would we consider cow milk protein allergy?
Okay, so the cow's milk protein allergy, see, always the approach will be a clinical, not the diagnostic. Like why we have done it, that's most important thing. So generally, we should have a visible blood. Only then probably I will go. Means visible blood is seen, then occult. No need to do an occult blood. Okay. So unless you have anemia and all, I will not do. Now, why? So probably here, I'll just put a theoretical case here. Probably are dealing with the infant early age, maybe 4 months, 5 months on mixed feeding, and child has a diarrhea, which is persisting more than 2 weeks. Is it okay?
Hmm.
And with occult blood positive. Should we discuss this scenario?
Yes, sure, sir.
Yeah, okay. Because the question, the answers will be as per the clinical perspective. So in this situation, again, means if the visible blood is seen, occult blood is no need to do. But if it is present very high, then yes, it is probably a significant one. One can consider, so it can be either one invasive bacterial infection also. So occult blood can be in. So first DD is like 80% of these diarrhea. I'm thinking, am I dealing with the bacterial infection? And then I will think of an allergic disorder. Now, it is important to diagnose the bacterial infection, but probably there is no hurry to diagnose the milk allergy. Few weeks of misdiagnosis or delayed diagnosis of a milk allergy is not going to cause any much significant long-term problem. So we should not jump to immediately to the conclusion of milk allergy. Nowadays, what I find is probably when I started practice, though I don't have a very long period of practice, just 8 years. So initially the diagnosis of milk allergy was very less. And now in 8 years, I find it is overdiagnosed also. So that we have to also consider. Now, any food allergy, when there are two system involvement, then possibility of food allergy is very high. So look for other system involvement also. So classical system involvement that we call it in a that we basically consider for food allergies. One is the respiratory, second is the skin, and third is the GI.
Hmm.
So isolated GI involvement will be around 20% to 30%. But 60% of the time, look for other associated symptoms. If you have other associated symptoms and your stool occult blood, probably as the child has atopy, diarrhea, prolonged diarrhea, which is going on for 2 to 3 weeks, you have taken care of infections and your stool occult blood is positive, then yes, I will consider milk allergy. But otherwise, if it is isolated, we'll see the other scenarios also. But yes, that we should keep that possibility in the scenario that you have mentioned.
And so what about, suppose there's an isolated first episode of fresh blood in stools in an otherwise healthy baby?
Otherwise, first episode of then again what are the
First
age?
episode of fresh blood, sir, in stool.
Okay, so we'll have to see. So if it is a fresh blood, then
Hmm.
the algorithm that we follow for approaching a lower GI, it will be a lower GI bleed. Fresh blood means will be between from the bottom area, that will be anorectal area and maybe a little bit sigmoid. So also we'll have to see whether it is coming with the mix with the stool or it is coming separate. If it is mixed with the stool, then probably I'm dealing with the colitis. Okay, and then again there is a standard risk of colitis. If it is a separate, then generally I'm dealing with the perianal region, some trauma, hard stool which has put some cut over there, this kind of thing. Polyps are rare. Vascular malformations are rare at this age.
Okay, sir. And sir, like as you mentioned, now coming to the lower GI complaints, sir, like suppose if we have a patient around 14 years old, and this girl, she comes to us with the third episode of diarrhea,
Yeah.
and she now when she comes this time, she is having watery stools, and there is nocturnal stools also present this time, sir.
Yeah.
But the last two episodes were there in last 6 months, and there is always there is a history that, whenever she goes for her classes, she eats vada pav also. So what do you think, sir? What are we dealing with with such a 14-year-old girl, sir? Third episode of diarrhea in 6 months, and but this time there are nocturnal stools also present.
Okay. Any pathological diarrhea, yes, there can be a nocturnal stool. So,
Hmm.
so basically, we are having. So, what is important over here is whenever the child is having diarrhea, what is the duration of one each episode of the diarrhea? Okay. So, whether it is a short or it is remaining prolonged, then how is she in between the diarrheal episodes? How is the
She's well.
how is the stool consistency improving? Is she well? Is she gaining her weight, gaining her growth centiles? Any extra GI manifestation? She's pubertal, has her menarche has stopped, so the menses has stopped, and number of things. So this looks like probably three isolated episode in between. Fine, this thing it might be a repeated infection. So just I will advise them to modify the lifestyle. These are the lifestyle related diseases.
And so suppose this same girl is unwell during in between the episodes, then how would we approach?
Yeah, so if it is an unwell, then probably we might be dealing with some chronic diarrhea with waxing and waning of the severity. So we will see what are her growth centers, is gaining weight or not. Examination, look for any extra intestinal manifest. I won't go in the detail because we have to cover a lot of points. So basically, in that my possibility, then I will work up for a chronic diarrhea at this age, the chronic diarrhea, the causes, so sometimes even the infections can keep on prolonging. Like suppose they have a history of travel, so travelers diarrhea can be prolonged. Again, the infections from the Campylobacter jejuni, Yersinia infection, they can have a prolonged infections. Third thing is the then celiac disease. Second decade also the onset is quite common. Actually, in any age, the celiac disease can onset till 40 years of age. So yes, we'll keep the celiac disease as one of the possibility. And then of course the inflammatory bowel disease like Crohn disease, ulcerative colitis, they can have also very a course which gradually evolves, and rarely maybe a tuberculosis. But TB
Yes.
is yeah less likely when they are coming with the diarrhea.
And so which test would we order if we are thinking about IBD? Which are the blood tests we'll order? Which are the stool related investigations one should order?
Okay, see, first thing is if have, I am keeping a clinical possibility of inflammatory bowel disease, then we should order one is the complete blood count and see what's happening along with the ESR. So we'll come to see what's happening to the hemoglobin, what's happening to the platelets. Again, it's very good acute phase
Yeah.
reaction for the generally most many of them, not in UC but Crohn's, yes, they will go up. Then CRP, ESR will be also elevated. It's very unlikely to have a normal ESR in IBD. We do get sometimes maybe a lab variation, but less likely. So these again will look for an albumin, what's happening. So generally these are the standard tests I do. I do not focus too much on a stool calprotectin when I'm dealing initially for the diagnosis. So generally, these tests are sufficient to see, okay, something wrong is going on. And of course, the closest differential diagnosis is the celiac disease. So one should also do a serology for the celiac disease. Of course, do not forget the secondary immunodeficiency like HIVs and all when you are dealing with the chronic diarrhea. So this much I will cover. So I will do TTG, IgA, and serum IgA. Both should be done.
Okay, sir. So, when I gave a scenario, you mentioned that this could be a chronic diarrhea which is waxing and waning. So, how would I differentiate it from a recurrent diarrhea or a recurrent bacillary dysentery? How should we differentiate it from that?
Sorry, I didn't get the recurrent bacillary dysentery.
Yes, sir.
So this thing is that if the episode is continuous or not. So that is more important. If you are getting a recurrent episode and then intermittently if the patient is responding, then probably may not. So in such situations, sometimes yes, we do face the situation where we are not sure whether we are actually dealing with because with the IBD or the repeated infection. Suppose sometimes there is the first episode of inflammatory bowel disease. Sometimes our inflammatory parameters may not be very high. So if you see the guidelines in such situation, one should look for the stool cultures. Now the stool cultures with us generally grow E. coli, and we don't know whether it is a pathogenic or not. So it's very important to see which type. So in such situation, we order biofire and see are we dealing with any actually the bacterial infection. Community acquired resistant bacteria are also seen when we are thinking it is more of an infective. Then sometimes if the oral antibiotics are not working, sometimes IV antibiotic do work. And then we see if suppose IV antibiotic also rule out Clostridium difficile because it is a recurrent diarrhea. Initially, child has received antibiotic. Now again the child is coming. So do look for the C. diff infection also. But many a time, mostly when there's diarrhea, people give the metronidazole combo also probably. So it does cover up many a time. So we do not clinically see it. So stool biofire or culture, one can do it. If it is not there, sometimes even the empirical treatment with the IV antibiotics, if there is no response, go for colonoscopy and look for the IBDs. It happens many a times that in the evolving phase, it is difficult to differentiate between the bacterial infection and the first episode of inflammatory bowel disease. Yeah, it is difficult sometimes.
Okay, sir. So, sir, when we feel that whether it is a first episode of IBD or it is a part of the recurrent bacillary dysentery, so will stool calprotectin ever help us at this point, or do you go for a scopy only?
So stool calprotectin will not help you in diagnosing. The only indication for stool calprotectin is one, you want to differentiate between irritable bowel syndrome and other inflammatory parameters. Okay, so that is generally done before scopy. Suppose the generally was used in an adults when they have very non-specific symptom and you don't know whether it's IBD or IBS. So if you stool calprotectin, it's normal. Probably you are dealing with IBS, so no need. So it is basically to avoid the scopy. In the children, if you are getting bacterial infection, if you are getting any of an IBD, whether it's Crohn's disease, ulcerative colitis, or it is again a tuberculous colitis, the stool calprotectin is going to be high. So I'm not wiser by doing a stool calprotectin. I'm just spending around 2,000 to 4,000 rupees of the parents and you get stool calprotectin like 4,000 kind of thing, sometimes 2,000. So they go crazy. The mother, father, they go crazy with those figures, and you end up in and admitting, end up in giving IV antibiotic because of 4,000. Okay, let's give you Nurofen. No, please do not do that. Let's not. Don't do calprotectin for diagnosis.
So it should not
We
be misused.
yeah, we should not be misused. So I sometimes in a diarrhea I do use calprotectin to choose whether I should do a colonoscopy or not. I mean, suppose the stool calprotectin normal, I will not do colonoscopy. I will just do an OGD-scopy. Okay, so that's how I use, but not for the diagnosis. Yes, for sometimes for selecting investigation, yes, for that. Now, another use of stool calprotectin are basically why it is used is to see the clinical response to the treatment of inflammatory bowel disease. One thing. Second thing, to pick up early relapses before the child becomes clinically symptomatic, whether I want to upgrade the treatment or whether. So for that we use stool calprotectin, but it has no diagnostic utility.
Okay, sir. And so there's a question for on this only is can the use of NSAIDs increase the fecal calprotectin?
Yes, so Dr. Shikha is asking the question. Yes, because NSAIDs can cause ulcers in small intestine. Even strictures are known with NSAIDs in adults. So whenever you have a denudation of intestinal epithelium, which has been so first, your neutrophils are going to be the first line defense. And they are cells from your innate immunity. They are going to be in the picture for any pathology, whether it is the NSAID induced, whether it is the infective induced. Okay, so NSAID is causing enteropathy. Yes, stool calprotectin can be high. Now it's very because probably the clinical scenarios that Dr. Shikha may be facing. Maybe they might be treating children with arthritis, and to screen whether they are not being treated sorry, not there not been a response, then to screen for IBD and the stool calprotectin may be done, and that's high, and colonoscopy may be normal. I'm just guessing, I don't know. So yes, so it can mislead, but what happens? Stool calprotectin will be high, do colonoscopy, and we will come to know whether it is normal or not. And if there is an ulcer, we'll take a biopsy and see. So that's fine. It won't change the diagnosis. Yes, choose of investigation. The one we may end up in over investigating, but that's fine.
Yes, sir. And so there's one more question on diarrhea only, but chronic diarrhea. In which scenario of chronic diarrhea should we consider it to be toddler's diarrhea?
So, so it's a very good question because many of Miss mothers. So in the toddlers diarrhea, mostly the mothers are basically they are very worried about the increased frequency. So toddlers diarrhea sometimes increased frequency. The stools may not be very well formed. That's and immediately mothers say they say खाता है वो जाता है कुछ पचता ही नहीं है. The first comes ये खाता है कुछ पचता ही नहीं है. Then first question, is he passing undigested food?
Hmm.
Okay, if he's not chewing, then yes, undigested food will come. But is it like chewed food is coming? So then only we'll say कि ये पचता नहीं है. So that can happen in a rare situation where there is an enterocolonic fistula. Otherwise, this will not happen. So if the child is growing well, then immediately there is a very strong gastrocolic reflex history is there, no nocturnal stool, and your clinical examination, child is doing well, then yes, we should suspect toddler diarrhea. It's very, very common.
And so how do we reassure such a mother?
First is a history, good exam. So there is no alternative to a good history and examination. So that has to be there. Sometimes you must ask the mother to take photographs of the stool, and you also see whether it is really a normal stool or not. And if the child is gaining weight, generally many a times they just need a counseling. Till they are worried, you just do a simple screening test, like see what's happening to the CBC, if ESR is high or not, how what's happening to the CRP, yes, albumin. If they are okay, generally is not required. If somebody wants, okay, you can add stool RE and see many abnormalities there or not. But this is just to maybe medico-legally safeguard us. Okay, you are not missing anything, but generally they are not needed. It all depends on what kind of family probably you are dealing with.
Okay, sir. So there is also one audience question related to diarrhea, but this is the normal, like the frequently when we see watery diarrhea, we're suspecting a rotaviral kind of a diarrhea. So is there any justification of using the residurotril in such cases
See,
or
Resicadrot.
loperamide?
Okay, see, Resicadrotil and Loperamide are two different medications. So Resicadrotil, basically they will decrease the secretion, intestinal secretion. So logically, yes, it might be a useful medication. It is more useful when you start early in the course of the disease. And if suppose in 2, 3 or 4 days not working, you stop it. It's not going to work. So there is no harm in using it. How much benefit it will cause, we don't know. Okay, but there is no harm if you see the pathophysiology how it works. It has not changed the mortality. It has not changed a lot of means, hospital. So it's not scientifically proven. It may not be very useful. If you don't prescribe, that's fine. Loperamide, absolute no, because it's going to decrease the motility. So it's not recommended to use the loperamide in the pediatric age group or any anti-motility agent.
And so when do you prescribe residurotril?
And I say, suppose others have not used, patient came to me and I don't have any other else things to prescribe. And then I prescribe because otherwise, I mean, if it's okay if you don't prescribe it.
Okay, sir. So one more question I'll take related to stool showing OB. So you mentioned that if the occult blood is above 3+, then you will be worried. So what is do we suspect Meckles that time? There's a question that infant with stool showing OB at 2 to 3+ repeatedly, otherwise healthy child. What is the best method to detect Meckles?
Okay. So, first thing, the Meckel's diverticulum, it is like very common. Now, how does the Meckel present? One thing is it can present with suppose a chronic diverticulitis, then there will be a pain.
Hmm.
Okay, then probably yes. And the classical presentation that it is a, see, remember it's a bleed from the vessel. It is not the mucosal bleed. It
Hmm.
bleeds. It bleeds torrentially. Occult blood. You are seeing the blood nicely. There is no need to do occult blood. Meckel diverticulum is a frightening kind of a blood. So stool occult blood, no indication of doing Meckel scan because it doesn't present like that.
And so the child will not be a healthy child, sir, right?
Because it will be very healthy child. Because it is not causing any problem. It's just diverticulum. Generally, they are very small, not enough long to cause small intestinal bacterial overgrowth, and they are episodic bleeds. Yes, anemia will be there. So, but they are generally healthy kids. That is a typical history. Is less than 2 years. If you are getting what I'll say, if you are getting a young kid, 2 to 3 years old, who has a visible blood and large volume where HB is dropping significantly and stopping on its own. Again, as you give more HB and you are establishing the intravascular volume, again it will bleed. See, the intestine, whenever there is an intravascular volume depletion, the
Please,
human physiology basically it will decrease the visceral flow, so the blood will stop. So that's how these Meckel's diverticulum or the visceral anomalies behave. So any 2 years old kid, this kind of bleed here, there, you should first do a Meckel scan. But if you are getting any 10 years old blood for a child with a bleeding, don't do Meckel scan. There the causes are quite different.
okay, sir. So now after discussing so much about diarrhea, we'll discuss a little bit about food allergies, sir. So, sir,
Okay.
suppose we have a patient, a 4-month-old, with history of peanut allergy in the mother, and now the mother has come to me and she's asking me like when should she introduce peanuts? Mother has peanut allergy,
So I'm not
proven.
an expert of a food allergy. Generally, the allergy specialist is the expert of the food allergy. Generally, the children will milk allergy, wheat allergy that come to us. Peanut allergy is generally not a GI manifestation, so they don't come to us. So I may not be the very right person to answer this question, but probably now the about the food allergy, the recommendations are changing from the late introduction to the early introduction.
Again.
Okay, so but we need to understand like how early introduction means what and what quantity. See, why there is no clear-cut understanding about the food allergy is because we don't know how the intestinal tolerance develops, food tolerance. Okay, till the time we are going to get the complete understanding, probably the questions will remain. Big study, something else will come. Another study, something else will come. Okay, and every 10 years the recommendation might change. Be open to it. Now, so whenever we are doing this introduction, probably the dose of the protein should be very small, and that has to be very scientifically given. So it's not that it's early there, so you give a lot of peanut. It has to be a very small dose. How much dose and all? Again, I'm not the expert. Just probably let's take an example of an egg allergy. Now we have IG mediated allergy and non-IG mediated allergy. Now for IG mediated allergy, they are saying yes, introduce an early food, which is an IG mediated one. For example, egg. Let's see the trials. Is a very nice good trial which was published in Lancet for egg allergy. Now, the amount of egg they have given for early introduction is 50 milligram. Now, in a clinical practice, how I'm going to prescribe a 50 milligram of egg protein? It will be actually 50 milligram of egg protein means probably 1 gram of no sorry even 1.1 gram of the whole protein, so it's very less. It is practically it's difficult for us. If we have, frankly speaking, if you have this kind of patient, please send it to the allergy specialist.
Sure, sir. And sir, how do you differentiate food intolerance from food allergy?
Sorry, food intolerance and food allergy. See, food intolerance and allergy, like lactose intolerance and milk allergy. So they are different terminologies. They are, it's like a intolerance is any intolerance, which may be allergy phenomenon or non-allergy phenomenon. And allergy is a something which is mediated by the protein and its component. Food intolerance is anything which causes the problem, which includes the food allergy. Want to separate between the two, then generally means let's separate for in terms of understanding on the basis of like lactose intolerance and milk protein allergy. So these food intolerance are basically a carbohydrate component of the food which your intestines are not able to digest. And your milk allergy is a immune mediated phenomenon. So where probably it is getting digested in small intestine, presented to the innate immunity and the other the B cells, T cells, and they are mounting the different response depending on what kind of food it is. So intolerance generally is the so allergy is all or none phenomenon. Means if you have an allergy, if you give a small amount, problem is going to happen. But intolerance is not all and none phenomenon. You can find a right balance where probably food may be tolerable by the intestine. Okay, so in such situation, if there is a symptom and if there are symptoms, so generally you, if you say the symptoms, you will get the symptoms of a carbohydrate malabsorption. We just discuss like a prototype is a lactose intolerance, where you have bloating, increase audible bowel sounds, of farting or loose consistency of the stools. So these will be more of a kind phenomenon of the carbohydrate malabsorption that will get in an intolerance. But if you decrease, the symptoms will be less. So that's how probably intolerance and the and the allergy can be differentiated.
Okay, sir. And sir, related to allergy only, Chokhani sir wants to know that should we understand that the recommendation of early introduction of potential allergen foods is not practically feasible for parents to practice, and it can be only be done in scientific setting?
Sir, I'm not expert. That's why I say I'm not expert. I think if somebody in the if in the forum is something allergy specialist is there, I think you're free to answer the question.
Okay, sir. No problem, sir. And so now moving away from food allergies, let's come to vomiting. So, sir, there are questions about vomiting that if there is a child who is having recurrent episodes of vomiting but is growing well, gaining weight, how should we evaluate such a child?
What is the age?
They have not mentioned the age. Let's consider 4-year-old.
Okay. So again, see, vomiting is a very big chapter itself.
Hmm.
Um, Whether it is really vomiting, whether it is a regurgitation, whether it is a forceful one, whether there is some pharyngeal problem. So it's very probably a broad thing. We have to always decide whether it is a really GI related or non-GI related. So if child is probably vomiting once a day, but there is no pain, nothing is there, mostly after the feed, mother has. Now you have to see whether it is after a forceful feeding the child is these are 4 years. Now he may be just watching mobile and mother or some caretaker or maid maybe just feeding the child. And child also maybe just because he knows the moment he stop the food, the screen is going to be go off. Okay, so he also keeps on eating. Okay, so you have to, if child is absolutely healthy, look for any forceful feeding, look for, do a good pharyngeal examination to see what's happening to the tonsils, is there granular pharyngitis, other things, is there postnasal drip. I'll look at these aspects. If child is absolutely growing well, occasional vomiting may not be that much significant also.
And so when do we suspect H. pylori gastritis? That's also a question.
So H. pylori gastritis, if your patient is having a epigastric pain, acute onset, not responding to the probably the PPI, then we will suspect. Now there is a lot of literature about extra GI manifestation of H. pylori. Very difficult to clinically correlate and practice. So what we do is generally we don't go and hunt for H. pylori. I want to diagnose H. pylori for that probably doing endoscopy or no. If clinically there is a epigastric pain, not responding to the PPI, probably the frequently eating outside food history is there. So this is so one can go and look for H. pylori. Apart from that, yes, vomiting, which contains sometimes the bleeding. Rarely there is an ulcer is there, so there can be a pain. There can be a so sometimes the ulcer can bleed. So these are the other extremes of H. pylori infection. So it's again a broad spectrum. Sometimes we get H. pylori as an incidental finding also during the endoscopy. So
Yes, sir. Epigastric abdominal pain could be related to H. pylori. That is one of the organic causes. So what about a functional abdominal pain? How do we approach a patient with functional abdominal pain, management wise?
okay, functional abdominal pain. Uh, so for this, probably everyone is now well sensitized to the functional abdominal pain. That is, I think, what I have noticed in the initial years of my practice, I used to see a lot of functional abdominal pain. But in last 3 to 4 years, practice has really the percentage of functional abdominal pain has really gone down. So the incidence of functional pain in abdomen has not changed. My referral is changed because probably everyone is very well sensitized. Pediatricians in Mumbai are very well sensitized for functional abdominal pain. Must congratulate everyone for this. I think everybody knows about it, but let's quickly touch the points. As per the Rome's 4 criteria, there is a good definition is established and the classification is revised. Now it is called as functional abdominal pain, otherwise non-specified. Rule out organic causes. Duration should be more than 2 months in a 12 months period and no red flags. So it means you will have to evaluate the red flag. Red flags may be a clinical thorough examination. So look for any abdominal findings, look for any extra intestinal manifestation. Third thing, you sometimes you may do some blood work to see any just basic screening work. Again, inflammatory parameters that we already discussed. So, what are the diseases which we look for, which should not be missed? One thing is the mark rotation. We should not be missing mark rotation. Okay, so but it will be associated vomiting. Look for examination, any gurgling sounds, and also that is one thing. Second thing, we should not be missing some subtle anemias and all there. We should not be missing the some celiac disease and all because the prevalence is Good. Okay, so these few diseases we should not miss, or early IBDs we should not miss. So rule out any red flag signs, and then counseling. Counseling again, look for the stressors. Most of the time, some it may be a study related, it may be family related. Sometimes it may be just the coping one. There may be no stressors, just the coping mechanism of the child. So they need a counseling. So all patients may or may not need endoscopy. So generally, if we also functional pain are generally the midline pain. So just now we discussed the H. pylori epigastric pain. So if you have a functional abdomen, so there is a functional dyspepsia also. This is a different category. So if you have a midline pain which is located in the epigastrium, so it's the dyspepsia, functional dyspepsia may be there. I'm not discussing that. Periumbilical pain are very classical for functional pain in abdomen that you asked for. And the third category of functional pain is hypogastric pain, which is associated. So it can be an IBS related. The difference between the constipation and IBS related constipation is after passing stool also pain persists, then again is that kind of pain. One. So many of them they need counseling. So the child psychology counseling it helps a lot. First thing you try to see the stressor, and sometimes just identifying the stressor and asking the parent themselves to sort it out the stressors helps many a times. If not, then take a child psychology consultation. Many a time the cognitive behavioral therapy, and then it really helps, makes a huge difference in their life.
Okay, sir.
So in this, what I will suggest is avoid painkillers. Like more you are using painkillers like cyclopam, NSAIDs, see, so their threshold for the pain will again decrease, and so the pain is not going to go. So first thing is most important is emotional support to the child. Do not tell that he is malingering or कुछ नहीं है ये बहाने कर रहा है नहीं. Do not do it. Just support him and tell the child, okay, you are fine. This pain is there. Everyone of us has this suffering from this pain, but we take care of it and we are strong like this. Just few words from a doctor can make a huge difference what the children perceive sometimes.
So, sir, regarding painkillers, are you suggesting that we should not prescribe painkillers in functional abdominal pain?
Yes, we should not.
Okay. So similarly, sir, Chokhani sir also wants to know, like in admitted patients, anyone who is vomiting receives PPI, irrespective of the cause of vomiting. So is it justified?
So, admitted patients vomiting. So again, let's see, you are admitted the patient, and we are take. So, what are the common causes of a patient when you are admitting for vomiting? Generally, there may be some GI infections or something. Of course, we are not dealing with the CN, raised hypertension and all. Gastritis and all is very common thing. It can be a many things. It can be infections. Even it can be a chemical gastritis. You can see, go outside, have any curry, such a nice red color curry. Never such curry comes from our kitchen. So there are many colors are added, though they are sanctioned colors as per the norm or the rules. But person to person tolerance of these colors can be different. Some person may be, so their case that what we call as a chemical gastritis can happen. Sometimes the person may be allergic to the other components. So admitting and giving a PPI is okay because you are admitted and each day cost. So the PPI is much much cheaper. If it's decreasing the cost, then definitely. So I will give it. So yes, I agree with you, sir. It is one of the most abused drug. But if you are admitting, yes, it's okay to give it. That's what I will say. At the same time, uh, now it's very important to understand how PPI works. PPI works when only when the proton pumps are active. In inactive state, it won't work. So giving them empty stomach is very important. Second, next step important is at one time, all pumps are not active. Only few percent of the pumps are active. Okay, so if I give the PPI now, maybe 60, 70 pumps are blocked. They are permanently blocked. Okay, but during the next one, maybe in the evening, remaining 20, 30% will recruit. Okay, so that's why your PPI action generally is do not give a peak action in the first 48 hours. If you want an immediate action, PPI is not the drug I will go for. I will go for ranitidine. Okay, so in the if I want to give it for gastritis, my go-to medicine will be ranitidine, not the PPI. But then, because I want to give it, because later on I do want the full action of an antacid medication, I'll give ranitidine, I'll give PPI. After 48 hours to 72 hours, I will stop ranitidine because I don't need. Now I have the highest PPI suppression. You stop after 2 days, and meanwhile your child is okay, discharge him.
Yes. And Dr. Sikha is asking, even with NSAIDs or steroid usage, is it at all necessary to prescribe prophylactic PPIs?
Uh, it's a basically there is a risk stratification in adults where they so no such risk stratification is there for the kids. So generally, if you see as per that risk stratification, kids will in the low risk category. So generally, it's not required. But if there is a history, yes, you do give it. So and it's the steroid. So many kids like they tolerate steroid very well. But then whom will tolerate and who will not tolerate, we never know. So I think scientifically not required, but maybe few percentage are coming. And then if there is a pain, then they may change the doctor. So these are very, means sometimes, yes, we know that evidence-based medicine is okay, but practically sometimes becomes so difficult. So sometimes I'll just say use wisdom.
Correct, sir. So similarly, there was a question about use of can granisetron be given in infancy?
Ganisetron probably not approved, pick off-label I use. Sometimes just pick, but I have not used it.
Okay, sir.
Are you guys using it?
Anybody is using it, sir, is asking if anybody is using and put it in the chat box. And sir, one word about, a few words about pancreatitis in children. What about pancreatitis in children, sir?
Mother, can you ask a specific question? Like,
So it's a non-specific question here, but so like when are you?
okay,
We'll leave that question. So we'll move on to another one. When should we consider cyclical vomiting syndrome, and how do we differentiate it from a metabolic disorder?
Okay, so the cyclical vomiting syndrome, so it's very difficult to diagnose in a first symptom. So the history is very clear. Here, the important is in cyclical vomiting syndrome, once it starts, so the number of times the child vomits is too much. So by definition, it should be 4 to 6 in an hour. Clinic, but actual practice, we do not get that intensity. Even the lower we do get, there is intense nausea, and once it starts, whatever you do, it doesn't stop, and then intermittently the patient is absolutely fine. Now, metabolic disorders, it's again a big umbrella. Exactly which metabolic disorders we don't know, but for example, which metabolic disorders in question, probably just
In general, it was a question, sir.
okay. So in such a metabolic disorder, suppose you want to differentiate in the first go. So what we'll do electrolyte, do blood gas and see if you are getting an acidosis, any alkalosis. If you are getting too much acidosis, alkalosis, probably you may be having metabolic disorder, but even in cyclical vomiting syndrome also, one can get the derangements. Again, look for the lactates, look for any alter sensorium. In metabolic disorder, you will get more the altered sensorium. Look for any end organ damage, like if there is a problem with the kidney, problem with the liver, no other things. So the brain is, so this generally they will be out of the proportion to the vomiting. There will be derangement in the metabolic syndrome. In cyclical vomiting syndrome, your vomiting is too catastrophic.
Yes. And just we also see sometimes girls who have just started with menstruation, when during their first or second day of bleeding, they come with excessive vomiting, sir.
Okay, I don't know. So they don't come to me, so I don't know.
Okay, sir, no problem, sir.
Like, what is the question? Like,
So the question is, sir, like a 13-year-old girl who has started menstruating in the last 6 months, every time she has a cycle, on the first and second day, she has excessive vomiting.
okay, probably it may be a part of dysmenorrhea. So I don't know any particularly when the vomiting as a component, don't have much experience, but when one can use the prophylactic ibuprofen in such patients in the initial one. But again, I'm not expert, probably one any gynecologist might be a better person to open.
Okay, sir. And so regarding the pancreatitis question, sir, is pancreatitis, acute pancreatitis common in children?
We should suspect there are two ways, like it can be a part of a systemic disorders like dengue syndrome and all. It may be quite common. Probably we may not be diagnosing it also sometimes. Then isolated, then as a pancreatitis per se, like it is limited to the pancreas. Yes, they are seen. It's not that probably every month we see few cases, one or two cases every month are coming to me. But of course, I have no referral practice. Incidence we don't have in from much incidence like population based studies, but at the same time the world's largest single center the studies are from India. Okay, so it's not just Indian population. We do see acute pancreatitis, chronic pancreatitis, recurrent pancreatitis. Yes, they do. Um, they do. There are. Yes, you should suspect it. Keep your eyes open. So
Yes,
again,
sir.
epigastric pain, acute onset epigastric pain. So organ that we suspect, is it coming from stomach? Is it coming from liver? It is coming from gallbladder, or it is coming from pancreas. These four
Fine.
organs we see, and you have it.
Yes, sir. So quick word about chronic diarrhea in neonates, how to evaluate.
Okay. When you are getting a diarrhea in unit, it's again we see whether it's like if any diarrhea which is less than 3 months, we always see approach it as a congenital diarrhea apart from the common disease. So the most common that we get is a bottle fed, other infections, rotavirus. These are the common ones. But if you're getting a chronic, persistent diarrhea after the rotavirus is again quite common. But suppose they are not responding to it to the enteral nutrition, then think of the other causes of the diarrhea. Few are like channelopathies, then like sodium channel, chloride channel pathies. Then there are the structural one like microvillus inclusion diseases or tufting enteropathies. Then there are subtle metabolic conditions like glucose galactose malabsorptions, hereditary fructose intolerance. Then again, if suppose they are adding someone sugar to the milk or giving honey, so do suspect that. Then apart from that, immunodeficiencies can also happen. So then milk allergies, as we just discussed, cosmic allergies again very common in neonatal age group. They can come.
Yes, sir.
So it
So
is a big factor.
yes, sir. So now we are almost it's 10:35. So I'll just ask you a last question, sir. So like if we get a toddler who has ingested a coin, so what should we do as a first contact person?
It is one of the costliest coin. So don't do anything. Okay, so in this, look for the location. If in
Excellent.
esophagus, so any foreign body in the esophagus has to come out in a 24 hours. If it is a button battery, within 4 hours, but coin within 24 hours. So suppose at 8 o'clock I get a call of a coin in the esophagus, I will remove it in the morning. I will not do in the emergency. Coin in a stomach, wait for 3 weeks. No need to rush for it. It will come it on its own. No need to give unnecessary exposure. Counseling works best. Try and elevate the anxiety of the parents. Most of the coins will come out. If it persists more than 3 weeks, you go and remove it. Don't send this child at emergency 10 o'clock, 11 o'clock, running from one emergency hospital to another emergency hospital. Very few people do scopies in pediatrics. So generally they are batted from one hospital to another hospital. Coins, absolutely, they are one of the less very harmless bodies. So if they are persisting beyond 3 weeks, then probably there might be some anatomical abnormality. Sometimes there can be a wave, sometimes there can be a pre-pyloric stricture or B1 stricture. Sometimes the size of the pylorus is small compared to the standard one, or sometimes just there is some non-specific motility disorder where the coin just remains in the fundament. It's absolutely normal. We remove after 3 weeks.
Okay, sir. Okay, fine, sir. Thank you so much, sir. Thank you so much. I think you have answered each and every question from the chat box.
No, I
All
have
that
not
we have
answered food allergies.
that is
That's not my
for
cup
an
of
allergist. So you had mentioned that before.
Yeah. Okay. Thank you. I think it was very nice discussion, interaction, and very innovative platform. Probably, I'll say. I'll congratulate all the IIP Mumbai team for this initiative.
So, of course, on behalf of Team IIP Mumbai, I also thank you, Dr. Vibhor, for making it very simple. I think the purpose of doing this is reaching out to all us practicing general pediatricians from a specialist point of view on very daily office-based clinical questions, clinical scenarios that we come across. It's not like knowing about IBD in a lecture, but it's knowing about all these small things that we face daily. And thank you so much for giving your insights, your practical inputs to the whole thing. And to the members also, that this is going to be on last Friday of every month. So I think most of you have joined this Webflix group, where of course, apart from the zones, the messages will be put up and the Zoom links would be shared. So everybody is free to attend it. And on this platform, I also take the opportunity of inviting all of you for our IIP Mumbai annual function, which is going to be on the 3rd of March, which is a Sunday at Garware Clubhouse. The messages have been going on WhatsApp groups, on our zones and mails as well. So it would be great that all of you join us on this occasion. There is going to be a Lifetime Achievement Award ceremony and there's going to be an installation. And the attraction, a cultural program by all of us IIP Mumbai members, all IIP Mumbai members. So everybody is most welcome for this. And sir, would you like to add anything to this, sir?
So about the installation ceremony, those who wish to attend, please inform the office so that we can get our numbers right. So please inform the office if you have already not informed them.
Dr. Vibhor, your name is already given, so you
Yes,
have
sir,
to
I'll
come.
be there. Yeah, thank you, sir.
Okay. Good night, everybody, and thank you, everybody, for joining us. Thank you so much.
Yeah, thank you. Thank you, ma'am.
Thank you.
Thank you.
Thank you.
Yeah, thank you, Dr. Deepa.
Thank you.
Thank you very much, sir. Thank you, everyone.
Deepa, thank you so much for moderating this so well.
Thank you, ma'am. Thank you.
I'll have to call you, Dr. Vibhor, personally to ask one of my questions which is unanswered.
Anytime, ma'am.
Thank you, Dr. Vibhor. You can exit. We'll just wait for the thing to get. Thank you.
Thank you. Thank you, ma'am. Bye. Take care.
Thank you. Thank you very much.